Welcome, everyone. I am thrilled to introduce Marci. She has been an incredible pillar of support in my learning and career, and it's so fun to have this opportunity to moderate for her. So Marci is a certified eating disorder registered dietitian, supervisor, and certified eating disorder intuitive eating counselor. In addition to her group practice, in 2015, Marci launched an online eating disorders training platform for clinicians. Marci identifies as a food and body image healer, practicing from a weight-inclusive and anti-oppression lens. She has dedicated her career to counseling, supervising, and teaching in the field of eating disorders. In 2016, she joined the Simmons Nutrition Department to co-develop a specialized eating disorder internship and teach graduate-level courses on nutrition counseling for eating disorders. In 2018, she received the Professional Integrity Award from the Behavioral Health Dietetics Practice Group of the Academy of Nutrition and Dietetics. She has spoken locally and nationally at numerous conferences and media outlets. So welcome, Marci, and I'll let you take it away.
Great. And likewise, I'm excited because I'm going to take a moment to introduce Casey. As she mentioned, she and I go back many years, more years than I realized. And was my tremendous pleasure to supervise Casey, particularly early on in her career. Casey is a certified eating disorder registered dietitian and supervisor, intuitive eating certified counselor, and family feeding specialist in Petaluma, California. She has a decade worth of experience in the field and currently sees clients in person and virtually. I'm going to go ahead and share my screen. And you'll let me know if something's not looking right. All right. It is an incredible pleasure to be here with all of you. I say that with gratitude and humility. Big thank you to Teresa, who extended the invitation to me to speak to each of you today. This is a different kind of talk for me. When I give talks or workshops or trainings, I am often digging into the scientific literature. I'm doing a lot with clinical application. And
Excuse me, Marci?
Yes.
We're not seeing your PowerPoint yet.
Okay, it says I'm screen sharing.
You're sharing your notes.
Oh, great. Okay, so I'll just do this way. Let me stop my share. And I'll share this desktop. Okay.
There we go.
There we go.
Perfect.
Thank you. So this is a different kind of talk for me because the ask of me was to share about my personal experience, to share my experience of shifting my clinical practice and utilizing primarily an IFS approach to my work. And so that is what I have to offer to each of you today, which is sharing from my experience in the hopes that it will feel helpful for you with a particular lens of sharing, of working with clients who have long-standing, enduring eating disorders. I do want to acknowledge that I come to this talk and I come to each of you today aware that I hold a number of privileged identities, and that those privileged identities shape my perspective and my lens, and also constrain my perspective and my lens. And I offer, through my own lived experience, appreciating that there are going to be limitations to that, and that I hope that some of what I have to offer feels useful to you in some way. I am struck by the lineup of the talks that preceded me, including Dick's talk last night and the conversation he had with Teresa. And as well as the two talks that Amy, as well as Wendy and Rebecca gave just prior to me. It was interesting because I didn't know what other people would be speaking on when I developed my talk, and I was really struck by, wow, in day one, in the titles of the talks, we have shame and shame and shame. So I feel really well teed up by the previous presenters, and a big-hearted thank you to each of them. So without further ado, let's go ahead and dive in. I have a little bit of a roadmap today. I'm going to spend just a short period of time giving you my own personal and professional process to internal family systems. I'm going to share a little bit of why I have found IFS to be a natural and really lovely fit to eating disorders work, and talking about what I am calling the 3 domains of influence, and really centering 2 client vignettes with 1 client that we're going to be spending a little bit more time with today. And I'm going to do my very best to watch my time to make sure we have time for a Q&A. So please don't be shy. Please, any questions that you have for me that pop up that feel related to my content or even tangential, I welcome, put it in the Q&A, and I'll do my best to respond to your questions. So a lot of the details don't really matter here, but when I mapped this out, what I was really aiming to share with you is that I have had about a 15-year journey with IFS. And I was very fortunate because early on in my career, attending the Meta conference in the Boston area, Dick Schwartz would present often. He presented a number of times, providing talks and workshops. So I had an early awareness of IFS. But it wasn't until several years later that I began my own IFS therapy and began to really delve more into my own self-study through reading and workshop attendance. And over the next couple of years, I actually tried to get my level 1 training, but was unsuccessful. I submitted into the lottery, I think 4 or 5 times. It was never selected, and have done my own self-study with the online IFS Circle program. And over the past couple of years, as I have really shifted my clinical focus to an IFS lens, have had incredible fortune to learn from amazing therapists who are IFS therapists, as well as in doing consultation and supervision with IFS experts. And I have to say, some of the greatest learning experiences I have had is by doing clinical supervision with my IFS colleagues, where we come together as dietitian and therapist and get supervision together. So that is a little bit about my process. Why do I think IFS is a really nice match for eating disorders work? This could be a whole talk in and of itself, but I'm just going to give you a couple of highlights. I have to own that I have bias. I mentioned that I began my own IFS therapy maybe 6 or 7 years ago. It is an approach that has a great deal of personal resonance for me. And through that personal resonance, there is a bit of a natural fit. There is a bit of if it feeling sort of accessible and kind of close at hand. So I do want to name that. I also want to say, and you've heard this in the conference already, and many of you attending this conference already know this because you're eating disorder specialists, is that there is a natural languaging when we're working with eating disorders, where we're talking about the part that wants to recover, the part that wants to binge, the part that doesn't want to get better, that we're already talking in parts. However, and Dick spoke about this last night, is that often there is a languaging in the eating disorder world that frames the eating disorder part almost like a monster or something terrible that needs to be gotten rid of. And that is something that's never resonated for me. And I love that IFS really shifts that to where we can be curious and open and actually grateful for these parts that, even though they've gone to extreme measures, have worked very hard in an effort to try to protect and serve the system. And it sort of speaks to this next little bit of the ways in which there was for me early on a very natural alignment to how I had long practiced as a clinician to what I feel IFS has to offer. I have felt and seen the ways for myself as a clinician and for my clients, the ways in which IFS is very strengths-based, as well as it's incredibly relational. Very early on in my career, I was very fortunate to have the work of relational cultural theory that's come out of the Stone Center in the Boston area be very influential in my career. And so working relationally with my clients has something that has always felt right for me as a provider. And there is this way in which you have the relationality between a clinician being a real person who gets to have parts, who doesn't need to show up as perfect and as healed. that I am in relationship with my clients, I'm in relationship with my parts, and I'm helping my clients build relationships with theirs. And as has been talked about a number of times already in this conference, it is incredibly non-pathologizing, which in relationship to what we've been talking about in terms of shame is incredibly helpful. And I'm going to be speaking about that in a couple of different ways today. And the other piece that I want to touch on is this way in which, as a dietitian, I have always tried to approach my clients with the understanding that I am partnering alongside them. I am not all knowing. I'm not telling them how to get better. I'm helping them locate that wisdom that lives inside of them. And IFS gives a frame for that in terms of the self, that a self lives in each and every one of us. And that lends itself to the last piece I want to talk about in terms of this alignment, is that we run the risk of some problematic power differentials between clinician and client that we have to be, of course, incredibly attuned to, careful of, bring into the room to discuss with our clients, and that we want to establish equitable relationships with our clients as much as possible, that it isn't a relationship of power over, of the wise clinician who is healing the sort of sick pathological client, right? That IFS really does away with all of that, and it invites that non-hierarchical, equitable relationship into the room. And I think very, very powerful ways, particularly as we're able to become skillful enough to speak for our own parts with our clients and with our teammates. I'll just say, related to that, is that I absolutely love that as a first step into IFS work, IFS asks us as providers to step in and do the work, to name that we have to know our own parts, be in relationship with our own parts, work on healing our own system so that we can be as self-led as we possibly can be when working with our clients. And IFS has just always been extraordinarily welcoming to dietitians. For those of us who have been in the field of eating disorders a long time, you may or may not be attuned to the ways that certain modalities have tried to minimize or even eliminate the role of the dietitian in ways that, of course, I have parts that have feelings about that, and I have really appreciated the ways in which there has been an openness that I have experienced from the world of IFS in welcoming us. And there was a question related to that last night in terms of the role of the dietitian and IFS. That's not the specific focus of my talk, but happy to speak to that if folks have questions. So that 3 domains of influence that I was talking about, I'm going to spend a little bit of time today reflecting on how IFS has been powerful for me as an individual provider, how it's been powerful in my relationships with my colleagues that I get to collaborate with, and of course with my clients. So I could speak pretty thoroughly about each of the bullet points that I'm going to provide here. I can just actually list them up on the screen. But rather than go through line by line, what I want to do is just sort of speak from my heart and say that IFS has been a gift for me to be able to draw on when we work with complex clients, and all of our clients with eating disorders we naturally have parts that arise for us, parts that carry shame, ways in which we can be critical, our perfectionistic parts, the ways in which we experience profound self-doubt, because the questions we ask ourselves when doing eating disorders work typically do not have straightforward answers. So we have lots of parts that raise up, and I find that, yes, experience goes a long way, that the more experience we accrue, the less burdened we become by our parts. But when we have IFS to lean on the tools, then I become less blended by my parts in and out of session, which means I'm becoming less burned out. I'm less worn out by those perfectionistic, striving parts, and those parts that carry shame. And that means that I have more space for creativity. I'm able to tap into my inner resources more easily, maybe when I'm feeling activated in session or I'm feeling stuck. And I can draw on my self-compassion. Yes, I still rely on my colleagues. I still rely on clinical supervision, but I'm more resourced, which means I have more energy and more capacity for my clients. Now, there's been some interesting surprises the more that I have brought IFS into the work that I do with my collegial relationships. And I'm not just talking about my colleagues who also utilize IFS, but I'm talking about my colleagues who maybe I have more challenging dynamics with. I utilize a weight inclusive approach. Not every member of every multidisciplinary team utilizes a multidisciplinary approach. And so that means there are often times when I need to lean into challenging conversations. I need to be an advocate for my client. Now, I spent many formative years in my family of origin learning how to skillfully and effectively avoid challenging conversations and challenging emotions. This work has invited me into working with my avoidant parts, my parts that want to be liked, my parts that want to do things perfectly. And I find that when I need to be able to really show up for my parts that feel maybe naturally quite anxious or reluctant to lean into challenging conversations, that I feel better able to do so. And also when I'm working with a colleague who maybe I'm like, oh my gosh, this is feeling, like a difficult conversation, or I feel like maybe they're kind of coming at me, there's a little bit more spaciousness inside of myself to be like, oh, yep, they're in a part. They're in a part. And even just that little bit is something that really helps me in those challenging moments. Now, I do want to put a plug in for what happens, the magic that happens when you are in the opportunity, and when I'm in an opportunity utilizing IFS and working with a colleague who is also utilizing IFS. And it has provided some of the most meaningful collaboration of my career. And I will say some of that is selfish on my part because for so many years, experienced so many challenging parts arise in the collaboration with my colleagues where I have felt, imposter syndrome, just intense performance anxiety. That has really gotten better over the years. But I have to say, when I am collaborating with my IFS colleagues who I have enough trust built, there's a relief that I've been able to experience in realizing, oh, I don't have to work so hard to hide the parts of myself that maybe I'm feeling a little bit ashamed of, that maybe I'm losing my patience, or I felt frustrated, or I felt anger arise in the context of, work that we're doing with our client, that I'm able to speak for my parts as I'm collaborating with my colleagues. And there's a sense of trust there, realizing, oh, this colleague's able to know that it's a part, it's not all of me, and that we're working together to help each other be self-led. And while it's not my colleague's responsibility to help me to unblend, I have some really generous colleagues who support me when I call and say, I'm having a really tough time. I'm feeling really blended with a part. And I have to say that when we're doing long haul work with clients for whom they have these long-standing eating disorders, that is an incredible gift. So now we get to dive into some really great stuff related to specific clients that I have had the enormous pleasure of working with. And I am not going to be getting into the details of defining long-standing or enduring eating disorders, but I'm sharing sort of this language, or sort of capturing it very broadly, of thinking of people for whom they've had an eating disorder for many years, and they have worked for many years to try to recover. And here they are many years in, still struggling, still hurting. Now, I want to share just a little bit about my clinical practice as it is now, because it's, I think, perhaps a bit atypical. For a variety of reasons, I have not accepted a new client into my clinical practice for about 7 years. So people recover from their eating disorder and then they move away from nutrition counseling. Over time, my practice has gotten smaller, and I have what's left is a smallish practice of people who I have worked with for anywhere between 10 to 15 years, which is not incredibly typical, particularly for a nutrition counselor. So that is the lens that I am speaking to today. And so it's maybe a little bit different of clients who've been with me for a very long time and who have been with me in making this evolution from a little bit more kind of traditional eating disorders approach, very behaviorally oriented, more CBT, more DBT, more ACT. I still dabble in and will sort of lean on some of those tools. But over the years and over the past couple of years to shifting to predominantly using internal family systems. So when we are working with clients who have a longstanding eating disorder, it will naturally evoke some unique challenges for us as providers. Now, these aren't entirely unique. These are challenges that might surface when working with clients early on, but they come into sharp focus, I think, the longer the challenge. So we're going to talk a little bit about how that shows up with chronicity and questions of recovery. We're going to talk about some of the ethical and existential dilemmas that arise, talk a bit about burnout and stuckness and shame. I'm going to pause for 1 second, grab a sip of water. I'm on the tail end of a cold, and I'm so grateful that this conference was not last week because I had no voice. So there is no universal definition for what we're talking about when we say recovery from an eating disorder. There's some actually really interesting literature published in the past couple of years. I really want to shine a light on the work of Andrea Lamar, who is a researcher and has her own lived experience. You'll see her name listed in my references if you're interested in delving more into that topic. But what we do know is that recovery does occur for many people. And for many people, recovery, however they define it for themselves, takes a very long time. I think this is well captured by the study here by Cameron Eddy, who is based out of Boston. She's an amazing colleague of ours in the Boston area out of MGH. And her team did this really cool 22-year follow-up study. And what I want to illustrate by the numbers here, particularly we'll see individuals with anorexia nervosa. At the 9-year follow-up, 1/3 identified as being in recovery or recovered from their eating disorder. The 22-year follow-up, it was another 2/3. I hope the takeaway for us is to never lose hope, right? That we are the hope merchants as clinicians, that recovery does happen, and it happens in unexpected and often in miraculous ways that we could never predict, and that it takes time for some people. And we don't necessarily know where we are going to be along the person's recovery process. But boy, is this something to draw on when we are working with individuals for long periods of time in our clinical practice. And that leads us to these dilemmas that we face as providers. And these are dilemmas and questions that it's my personal belief that are inevitable when working with clients for many years, that are essential questions to ask, but that are questions that do not have clear-cut answers, which is one of the many reasons why being in relationship with ourselves and being able to show up for our parts that arise when we're asking these kinds of questions. Am I helping this person recover? Am I even helping? Would they be better off with someone more experienced, someone with a fresher perspective, someone with more IFS training, right? We ask these questions. Am I supporting healing and growth, or am I inadvertently and certainly unintentionally colluding with my client's eating disorder? Am I enabling stagnation? Am I even capable of helping this person? What are we actually doing? What are we doing in this treatment? These are questions I have asked, and as a clinical supervisor, these are the most difficult questions that my supervisees bring to me. What is my role in less mainstream treatment models like harm reduction, palliative care, hospice. And often a very terrifying question that we face as providers: is my client dying? Is there a chance that my client might die? Am I doing all that I possibly can do to help keep my client safe? So these are unbelievable and challenging questions that arise for us. And it's no wonder that when working with mental health, it's not unique to eating disorders, right? All of us in a variety of helping professions do experience burnout. Now, as I was developing my presentation, I thought, well, I should go into the literature, and what does the literature say about burnout? And I was like, you know what? I just sort of from my own mind typed out all of the different sort of variables that I could think of that contribute to a clinician's experience of burnout when working with clients with eating disorders, particularly over long periods of time. And we see quite a challenging list here. And I have to tell you, as I was practicing my talk, I was like, oh, there's like a part of me that doesn't want to include this slide. I don't want people to come to my talk and get bummed out or sort of feel discouraged or turn anyone away from working with eating disorders. I had my part that was sort of saying all this because I absolutely love doing this work. And the reality is it's exceptionally challenging. It's one of the reasons why I so believe in having network of collegial support, clinical supervision, and of course, as I'm talking about today, IFS as one of the many things that we can lean on when we are feeling the difficulty really weighing on us. So what I'd like to do for a moment is sit back a little bit and invite anybody who wants to share in the chat. Doesn't need to be in the Q&A, can just be in the open chat. If you feel like you would like to share what emotions and or parts arise for you when working with clients with eating disorders, and if you have experience working with clients with long-standing and enduring eating disorders, what are the parts that you notice tend to come to the forefront the most? And unfortunately, oh, maybe I can. Oh, I can actually, yay. Okay, I can see it. Casey, I thought I wasn't going to be able to see it, but I can see it. Teresa says the fix it part. Amen. Amen and hallelujah, because we have parts that are panicking. Compassion, beautiful. So you have yourself right there. Protector, worry, urgency. Yes, feeling incompetent. Yes, Margaret, I feel you. Problem solver, frustration. Frustration that I'm not good enough, right? We turn it in on ourselves. Frustration. Hopeful and hopeless parts, Jamie. I am so there with you. Incompetence. Fix it. Frustration. Yes, 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 yes. Angry at diet culture. We get righteous. A parenting part. Hi, Stephanie. Danger, WTF, yes, perfectionistic. Oh my gosh, Amanda, we know our parts so well. Exhaustion, yes, activated, just getting activated, feeling anxious, imposter syndrome, Caroline, big time. Hopeless, we get scared, a little soapboxy. I totally appreciate that, Stacy. Bodily insecurities, thank you for naming that, Tracy. You're not alone in that. Yes, I'm not able to be the provider. Maybe maybe I'm feeling like I'm too sick. Hi, Kylie. Yes, yes, just get better. Yes, we have parts that get annoyed. How protective those annoyed parts are. Yes. They tell me I have to give up on the client. Fatigue, hopelessness, angry, tired. Thank you. Thank you. Thank you for sharing. Yes, attachment to outcomes without a doubt. Fatigue and frustration. What am I missing? When will this ever be effective, Diana? Thank you. Yes, I think, yes, what more can I do? Should I do more? Yeah, why am I not good enough? Isn't it so amazing how we as providers turn in on ourselves and there's this parallel process, right? Of our clients are not feeling ever good enough and we're not feeling ever good enough. Um, Thank you everybody for your generosity and sharing. I think that there is so much that we gain from hearing from one another's parts that arise that we are not alone in the parts that I get like a little bit teary. Yes, feeling so seen, right? That we have these really tender, vulnerable parts that come up. Ooh, I did not expect to get choked up. I expected to get choked up when I share for my client. I didn't expect to get choked up right now, because underneath all of that is this incredible vulnerability and empathy and compassion and great heart that we bring to this work. So of course we have protectors that come in really strong, that get all kinds of frustrated and worried and scared, and start managing in ways that are unhelpful. Yeah, deep sadness. Thanks for the love, Lynn. So I'm calling on the wisdom of my longtime supervisor, Beth Mayer, who you're going to get to hear from this evening, is that she provided me with the guidance very early on in my career that when we are seeing stuckness, even if it's for, a reasonably short period of time, but certainly if we're seeing stuckness over long periods of time, we as providers need to look at ways that we can change something up. And that changing something up is sometimes very small. Sometimes it's us unblending from a part. And sometimes that changing something up is really big, like getting a client to a higher level of care. But that wisdom has stayed with me my entire career, that when we stay with something, staying the same for too long, we run the risk of getting into stuckness with our clients. And sometimes our parts grab for changing up, coming from a caring place, but not typically effective. So the goal being, how can we work towards shifting things from a self-led, heart-open place? And unexpectedly, for me, is that one of the big somethings that has shifted has been moving to utilizing IFS with my clients for whom they have done years and decades of more behaviorally oriented treatment. And that is not to say it is all or nothing. It is not black and white. There's a lot of gray and a lot of nuance that's happening. But I will say that for me as a provider who asks those really difficult questions of myself, because I owe it to my clients to ask those questions, and it's helped me feel the clarity that I'm not simply circling the drain with my clients over 5 and 10 and 15 years, but that we are coming at this from a different, and I will say with IFS, what I experience is a deeper way of getting in and doing the work. And I'm going to share with you 2 client vignettes. The first is going to be very short. The second one's going to be a little bit longer. And so what I did is, in preparing for this talk, I emailed a handful of my clients and I said, no pressure. I'm giving an IFS talk. If you want, I'd be so curious if you would share your response to these questions. And their response to these questions are what I'm going to be sharing with you. And I only felt sad that the whole presentation couldn't just be like me reading my client emails, because their wisdom and their vulnerability and all of that was just like, I was crying with every email that came in. And then I was forwarding it to like the team members, like, you got to read this. So everything that I'm about to share, I want you to know that I received consent and permission, and I'm highlighting some of the challenges in the work, and it's so brief what I'm sharing, but I want you to know that without a shadow of a doubt, each of my clients come also with the most incredible strengths and strategies and parts that are just like so life-giving and such a pleasure for me to work with. So you don't maybe get to see into as many of the strengths. I had a part that was maybe worried about that as I was developing this talk. Okay, so I'm going to invite and introduce you to my first client. She utilizes she, her pronouns. She's 43 years old. She's Caucasian, she's lesbian, and she's a single mom by choice. She's a school teacher, and her amazing therapist is here today. She has a 30+ year eating disorder history. her current presentation, she meets diagnostic criteria for atypical anorexia nervosa, which is, we all know, I should have put it in scare quotes, terrible term. She has anorexia nervosa. She has anxiety, depression, attachment challenges, obsessive compulsive tendencies, and she has endured multiple traumatic losses. She and I have been working together for 15 years, and she has a new IFS therapist who she's been working with, I think somewhere maybe approaching a year and a half. And she worked with her previous therapist for 20 years. The previous therapist is not an IFS therapist, an incredible therapist who did important life-saving pieces of work with this client. And this client really eventually became very clear that she wanted to do IFS therapy. And it was a big accomplishment and a big piece of her work to leave and close things up with that previous therapist and open up and begin this new relationship. She has a number of significant barriers to recovery. Two here that I'll share with you is that she has parts which depend on illness, her eating disorder, as a way to be connected, to feel cared for. I imagine many of you are resonating and have clients where they feel similarly, and that can be very challenging to work with. And that she identifies as parts, having parts which utilize the eating disorder to make up for what these parts call her badness for being gay, for example. So I reached out to her and I asked this question first. What has it been like for you to shift toward an IFS paradigm in our work? After being in therapy and nutrition therapy for over 20 years and having tried a large number of modalities, IFS has been the one that has really clicked in allowing me to understand the root of my behaviors with compassion and curiosity. After a year and a half of intense IFS therapy with a therapist, plus my work with Marci, I've finally been able to allow the restricting protector to step back a bit and give me the space to eat again. What aspects have felt helpful, unhelpful? It has been helpful to develop the concept of self. When I first started IFS, I did not believe I had a self. Now, and this is holy moly, tremendous work that she's done with her therapist. She's beginning to believe that she does have a self. She says, my parts are beginning to develop a relationship with self and to trust self to make decisions that will be beneficial to the entire system. I was worried that IFS was going to make me feel more alone because I would have to rely on self and not others. However, I am learning that a crucial part of self is being in connection with others. The most helpful part in regards to the eating disorder has been the ability to understand that the part has had an important function and it is not something to get rid of or blame. Up to this point in treatment, my eating disorder has always been seen as something bad, something I have to get rid of, and that is hurting me. With IFS, I am able to see how the part has helped me and isn't something I need to push away, but rather bring closer and understand and show gratitude too for helping me survive. By bringing the part closer, I have been able to help it relax a little and give me the space to try things a different way. What do you think are the benefits or drawbacks to utilizing IFS in your eating disorders recovery? Only benefits. IFS has helped me so much. This is the one therapy that I feel really resonates and makes sense in understanding myself and my parts deeply and with compassion, thus allowing me to change harmful behaviors. I would say that working with an IFS therapist as well as Marci has been imperative. It doesn't work instantly and is really deep, hard, emotional work, but it is worth it. My second client, I'm looking at my time and I thought that maybe I wouldn't have time to share her with you. And so I'm going to leave client 2 for you to spend time with on your own. And I'm going to move us forward to my third client. And this client is named Deb. That is her real name. She is very happy for me to share with you her name. She is a performer at heart, and she was very excited that she was going to be sharing the stage with me. She utilizes she, her pronouns. She is 42 years old. She is Caucasian, single. She identifies as super fat, which is a term from the fat liberation community to describe someone who wears a clothing size between 26 and 32. She works as an academic administrative assistant. She has a 30+ year eating disorder history. Current presentation, she'd meet diagnostic criteria for OSFED, generalized anxiety disorder, depression, and while not a specific diagnosis, she has severe weight-related trauma. And as Amy spoke about brilliantly in her talk this morning, we are very aware of the ways in which weight-related trauma beginning in childhood really manifests as complex trauma. She and I have a 13-year working relationship together, and she is currently seeing a self-described eclectic therapist who is IFS informed. She has experienced a number of barriers to recovery, including financial barriers to accessing adequate, well-matched treatment that is trauma-informed and fat-positive, although she has all of that now, which is incredible. She experiences the ongoing trauma of living in a fat-phobic society in a fat body, and she has parts which blend with her and flood her, particularly highly self-critical parts that see her as incapable. So I received Deb's permission to share with you some of the parts that we have gotten to know together and that we have been building a relationship with. The first, I got ahead of myself. I'm going to give a little bit of a background on Deb. Her parents met in Overeaters Anonymous, so that makes us curious a little bit about legacy burdens that Deb might be carrying. By the age of 8, she already began experience significant and repeated body criticism from multiple family members. At the age of 10, her mom took her to her first diet program, and the next ensuing decades were a terrible roller coaster of dieting, weight cycling, overexercising, restricting, developing an eating disorder, which has shown up as atypical anorexia, OSFED, and binge eating disorder. She was referred to my practice by an incredible and unicorn doctor who was an eating disorder specialist, practiced from a weight-inclusive lens, referred me to my practice, and she was expecting to be put on a diet because she did not yet know that she has an eating disorder. Okay, now we're going to get to know some of Deb's parts. One of the very first parts that we got to know was a part who she lovingly calls black hair. And this is what Deb has to say about black hair. She seems scary because she gets really angry. She's really not scary. She's there to make sure no one puts me on a diet ever again. When she's in charge of the food, it has an F you, I'm eating whatever the hell I want and you can't stop me sort of quality. I love her because she's fierce and she is there to make sure I don't get hurt by a diet culture and fat phobia again. She showed up at 13, took one look at my family and said, I don't think they're right about you, Deb. She has a part she calls the quiet one. She believes safety is in stillness and quiet and often does not get listened to. She loves reading and being alone, and she came along when I was young because my house was so emotionally chaotic and loud. She is very gentle, but she's also afraid a lot. Her job is to keep things chill. She's secretly who I wish I was because I hate that I have such big feelings and loud opinions. Or a part of me hates that and wishes I was her. The critic. She wears me out, and I feel so exhausted by her. She is so loud, so present, always telling me that's not enough. It even tells me I'm not doing IFS or recovery right or well enough. It questions whether I'll ever feel better than I do right now. I know she's trying to protect me, but I get really blended by her and have a hard time meeting her with openness and compassion. She has a part who we recently met that she calls the spiky yarn ball. This is not a human part. My parts experience this one as very dysregulating. It doesn't have words but emits sensations. It vibrates and hums, letting me know there is danger everywhere. It lets me know that I'm off balance. I'm on a cliff. All of my other parts are dysregulated by this one. I know it's trying to warn me of trouble, keep me on alert. binge eating part. This one steps in when I don't know what to do, when I am totally overwhelmed and my little one is panicking. There is so much I don't know about this part because it's the hardest to access. So many of my parts don't want to deal with her. I have parts that hate and feel ashamed that I still binge eat sometimes. The diet coach has very specific ideas about what I should be eating. It gets really loud when I have to make food choices alone, which is why I prefer to eat with others. I just eat what they suggest. I go along with it because otherwise she steps in and I get very overwhelmed. Then she and black hair start fighting. And my watermelon girl, my 7-year-old exile. I may choke up. She tries really hard to not be difficult, but feels responsible for things she doesn't understand. She's often worried that no one is in charge, that no one will take care of her, and feels pressure to be more grown up and capable than she is. She feels deeply ashamed that she's not responding like she is supposed to. Her primary emotions are fear and shame. And that's my default with food. I'm either afraid or ashamed about my eating. Now my work has evolved and had many, many chapters with Deb. Recently, we wanted to kind of get some more clarity about the focus of our work. It was very interesting in our session as I tried to get that clarity with her. It seemed like she was kind of moving away from the conversation, and I had a sense that she had parts that maybe we're trying to avoid, or sort of didn't like the questions I was asking with what feels most important for us to be focusing on. And when we explored that together, when I got curious about that, she said, Marci, I know you're not even asking me to set goals, but just the process of identifying a focus to our work makes me feel like I'm back in a dieting program again, that I'm 10 years old and that anything I put on paper means that I'm going to fail. Anything we identify just by naming it already means my failure. And we were able to do this beautiful piece of work of talking about autonomy and consent and sharing a vision together. And it was this beautiful healing experience. And what we came up together with in terms of identifying our framework is that right now we are working together on identifying, helping her unblend and befriend parts that get triggered by anything food or movement related, placed in the context of her childhood and ongoing food and body size trauma. And you'll notice we're not working on the food, working on the movement, we're working on the parts that get activated and just getting curious about those things. And similarly, we're also trying to help the parts that react to self's wishes, self wanting to be values aligned and self-led in her relationship to how she's caring for her body. And we're continuing to build those self-to-part relationships. My last couple minutes, I'm going to read for you Deb's responses to my questions that I sent my clients. I'm going to close it up and open it up for questions. What has it been like for you to shift toward an IFS paradigm in our work? The IFS paradigm has been truly life-changing. It's such a strange concept. It was explained to me years before Marci started using it, and I remember thinking, that is so weird. But it really works for me. Identifying my parts, giving them an imagined physical form, an imagined home bus, depending. It creatively brings my coping mechanisms, thought patterns, and inner thoughts into the forefront of my mind where they get to be not just heard, but appreciated. I had one part in particular, black hair, I call her my angry part, that I had locked in the proverbial basement for my entire adult life. My other parts were afraid of her, and when she would come out, it seemed as though she was always aiming to harm. Through IFS, through listening to her, through being present with her and introducing her to self and to Marci, she has become a beloved part of my emotional ecosystem. She lives out in the open where her fierceness can be consulted and honored and utilized when protection is needed, mine or other loved ones. And after I had that experience, I knew it was possible with other parts that are hard too. After many years of fear, Marci and I have started working with my child part, a very fearful yet playful 10-year-old, and I feel like she is already more integrated than she was before. Now that I have more skills of introducing my parts to self, I find myself able to do it with more frequency outside of my sessions. Using IFS has helped me through panic attacks, relationship challenges with family and friends, and challenges in being an auntie to some awesome little girls. I'm so grateful for it. What aspects have felt helpful, unhelpful? An aspect that sometimes feels scary to some of my parts is the idea that self is the one responsible for everything in my ecosystem. But as a religious person, I have started to imagine my parts coming into contact with both self and God. This has been incredibly helpful to me that not only is self present and in charge, even larger God is. I often imagine God scooping up self and whatever part we are learning from and rocking them both, rocking me, soothing and adoring and powerful. I feel like IFS has in many ways healed my relationship with my more challenging emotions. I am the type of person who just wants, insert emotion here, to be over. I'm like, yes, I relate, Deb. So those selves were constantly being pushed into the basement. The amount of tenderness I've developed for my anxious and fearful parts, it almost makes me want to cry. I'm so grateful for it because those parts are me. Part of how my eating disorder manifested itself as a child and young woman was with extreme self-abandonment, a habit I learned from and reinforced by both my parents, especially my mother. My youthful, swarthy Lebanese body was a representation of needs that should be repressed because my body was something to squeeze into thinness through whatever means necessary. As an adult, as a growing and changing human, I want nothing more than to be an advocate for myself, to be present for my younger parts, to be the adult that they needed. And IFS allows us all to get to know each other, to have them experience the security they needed as a child, now through self and through God. What do you think are the benefits, drawbacks to utilizing IFS in your eating disorders recovery? I love stories, love characters and narratives, particularly those that revolve around true humanness. So IFS really taps into a creative part of myself, which is why my parts feel so vivid to me. And I love the aspect of giving them form or place, or I should say, finding out their form and place. I love the community of people inside of my own self, and I'm loving seeing them all grow and change and become more of what they were meant to be, silly or fierce or organized or protecting. I know that was a lot of reading. I couldn't bear editing out Deb's words. I'm going to end it there. What more beautiful place to end than her wisdom? Thank you so much, and we'll see what questions I have time for. Not quite as much time as I had hoped, but I did my best.
Thank you for sharing those, Marci. Those were so touching, and please thank your clients too. Wow. Here is our first question. Can you share more about how you found an IFS specific supervision community with both RDs and therapists that worked for you?
Oh, well, I think I am very fortunate being in the area that I am in the Boston area. It is one of the greatest gifts that I have had as a professional to be surrounded by incredibly generous, wise therapists. Um, and so some of that has been collegial relationships that I've built over many, many years. And so there's been a little bit of timing, luck in the timing of it. But I will tell you, and you're going to be hearing from an amazing dietitian tomorrow. Well, two amazing dietitians, Diana and Molly, for those of you who are going to their breakout, and Diana's in my neck of the woods. And so I've also sought out Diana just because she's been in community. We've been in community together. So I think it's a little bit of luck, actually. I think it's been a little bit of luck. These are relationships that I've had over long periods of time and special colleagues who have been delving into IFS. I wish I had a better, more relatable, a response that was more useful than the honest one.
Right. So the next two are actually about the same. I felt drawn to this lens for a long time and slowly started to learn more individually and professionally because it feels right. Let's call it self-energy alignment, if we will. I know a part of me fears being told you're a dietitian and shouldn't do this work, or you're not allowed to. The scope of practice talk that I think so many of us have been taught to fear or not see as expansive. What has your experience been with this? And can you share how you have supported parts concerned about scope of practice?
So this is it's a really important question. Oh, thanks, Diana. Oh, thanks for the love. It's so nice. I appreciate it. I always have a little bit of a vulnerability hangover after I speak, so the love is just thanks. Scope of practice. I think dietitians are never going to stop hand wringing over scope of practice, and I say that with love. Um, the scope of practice concern tends to be there whether it's IFS or a different type of counseling modality. And I think that it is important for us to be asking, am I utilizing counseling tools in the service of my role? And that is filled with an abundance of gray because our role is actually informed by a couple of things. One, my role as a dietitian, what is the job of a dietitian versus a therapist, but it's also informed by the extent of my training, right? So my role is going to expand and contract. If somebody was to say, Marci, what's your role with EMDR? I would say there is no role. I have no training in EMDR, right? Whereas my role with IFS is more robust than somebody who hasn't had any training, but it's not as robust as Diana and Molly's, who have significantly more training than I do, right? And so there is this comfort where parts, one, we have a lot of parts to identify. One, dietitians tend to be rule followers. We tend to have difficulty with conflict. We tend to get worried about people, thinking, negatively about, what we are doing in our role. These are like pervasive things that I see over and over with the dietitians that I train. Part of that is informed by how we are trained academically, which is within a medical model. So we have parts that want things to sort of feel comfortably defined. And so when we are working with a therapeutic modality, it means things get a little bit blurry. And in that blur, we have to continue to explore inside of ourselves. What is this discomfort showing me? But we also, I believe, need to be regularly taking it to supervision to explore what's mine and what's not mine. Ideally, I think if you're really lucky, you get to have either a dietitian who has robust experience in sort of therapeutic training and sort of training in counseling, and or you have a supervisor who is a therapist, which is like the gold mine. And the other piece that I want to say, oh, I lost it, but it might come back to me. But I just really want to honor that this is what comes up all of the time, whether it's IFS or something else. And we do have colleagues who will push back or who will say, I don't think that's your job, or why are you talking about this, or why did you bring that up? And I think the more work that we do to identify what parts does that hit in particular with me, we can lean into those conversations from a self-led place where we can say, tell me about your concern. What is your worry? Would you feel comfortable with me offering my perspective? Can we get comfortable with the fact that we might have two different opinions? How are we going to reconcile that? That is extraordinarily difficult to do. And if you're really lucky like I am, um, you have colleagues that you collaborate with where you can say, I am this opened up into your territory. I am thrilled to now pass it over to you, the psychotherapist. So there's a lot that we could say in response to that question. This is such a brief response to a really important, a complex question. It deserves its own talk in and of itself. I'm not sure if we have time for one more, but that might be where we need to.
Yeah, we have two more, but we will make note of them and answer them and send them out later. So I will make sure to take a note of those. And then I was informed to tell everyone. So as soon as you leave here, go back to the attendee dashboard and log back in because we have a quick turnaround to the next presentation. But those last 2 questions I'll make note of.
Thank you so much, Marci and Casey. That was fabulous, Marci. Thank you so much for bringing your experience, your wisdom, and your clients' hearts and your heart into this presentation and your work. So grateful.
Yeah, thank you.